Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher, and this is episode 53 of our podcast today. We are at our one-year anniversary, and we have over 24,000 listeners now. Number one on 3 platforms, including iTunes, Stitcher Radio, and TuneIn. And also Sirius XM Radio is showing us some love as well, since I have a spot on the doctor's channel there, but also looking at possibly making this a formality on the satellite radio service. So we're pretty excited about that. So I hope everyone's doing well. I hope you're having a good day and a good weekend. As much as I love saying this and sharing it, my Pittsburgh Steelers continue to win. We're at 3 in a row right now, so all positive vibes in my house the past few weeks. And I'm just happy baseball is finally over. I mean, 162 games, but then you get into the playoffs and you're just like, can it just be done? I have been a baseball widow now for about, 6 months. I'm kind of over it. So luckily now my husband gets to deal with me during football, even though he's 2 clicks away from painting his face for the Steelers as well. At least I'm joining him on this one. So today I want to have a conversation with you about what is going on in the fee schedule. So the Medicare fee schedule came out today. Actually, I'm recording this on November 1st, so you know it's not dated information. It's actually current, which I do pride myself on. And I don't always like to date things since people go back and listen, but I want to make sure you knew when things came out. Last podcast, I was actually going to talk to you about offshore, sending your billing offshore and outsourcing and things like that. And I still want to talk to you about that and have a conversation, but I'm going to do that next podcast because we've had some breaking news. And it's good news. Some of it is. And then there's some news that you just want to prepare yourself for, but it's important that we get it out to you and really talk about it because you're going to have to deal with it in 2 months. So we want to really talk about the breaking news. But first, the Codecast podcast is brought to you today by Healthcare Executive. Healthcare Executives Network is the fastest growing community for healthcare executives and their trusted partners. HealthcareExecutivesNetwork.org. And Keck Medicine of USC, over 500 nationally renowned physicians at a leading academic medical center, keeping you healthy, on track, and doing things you love. KeckMedicine.org, ranked in the top 50 hospitals in the country by U.S. News and World Report, and number 1 in Southern California in cancer care. Okay, so here we go. Let's pull up some of this information. So what was published today was the final policy payment and quality provision changes to the Medicare fee schedule, and it's for the calendar year 2019. And for those of you that wanted to go and look at the fact sheet yourself on this, you can find it at cms.gov/newsroom/fact-sheets, and then / final/policy/payment and quality provisions. So you'll find this on my website as well. I'll have a link to it just so that you have it at terryfletcher.net. But let me just kind of give you what's going on and really what CMS is issued as far as their final rule. So it includes updates to payment policies, payment rates, the quality provisions for services, again, under the Medicare fee schedule, physician fee schedule, starting January 1st, 2019. And it does reflect a broader administration strategy to create a healthcare system that results. They want to really focus on accessibility, quality, affordability, empowerment, and innovation. At least that's what they tell us. So, that's really their kind of their pitch right now when you look at that. And so when you talk about the fee schedule, we're talking about visits, surgical procedures, diagnostic tests, therapy services, and certain preventative services as well. And then in addition to physicians, payment is made under the physician fee schedule to nurse practitioners, physician assistants, physical therapists, as well as radiation therapy centers and some independent diagnostic testing facilities. You might have heard this referred to as an IDTF. So the payments are based on relative resources typically used to furnish the service. They call these RVUs, or relative value units, and it's applied to each service for physician work, practice expense, and malpractice. And so I'm just going to kind of run through it with you just so you have it and can kind of listen to it, because I know we all have so much time in our daily practices to go through and read let me just tell you how many pages this is. 2,378. I kid you not. So I've gotten through 400 pages. I skipped right to the fee part of it, but I'm actually going to be reviewing all of it so that you don't have to. I want to be able to let you know what's going on, and you can look at it as a book on tape if you'd like, but I will be podcasting some of the other details as we move forward later in the year. Look forward in December, so right before you're going to start. That way you can really focus on, getting your month end, your year end done and everything, but just know I'm going to be here for you. I'm going to go through everything. And one of the second to last podcasts, I'll probably go ahead and just say, okay, here is your fourth quarter update. Get ready for it. So let me give you the gist of some things that are going on, and just so you can really at least be aware of it, because it's going to affect your practice. And so let's take a look first of all. So payment provisions. CMS is finalizing a number of documentation, coding, and payment changes to reduce the administrative burden, they call it, and to improve payment accuracy for office and outpatient evaluation and management services. Now, remember, the proposal said as of January 2019, they were going to go down to a single payment system for office visits and new patient visits, again, office only, that were between level 2 and level 5. But now it says that they're going to implement this policy over several years. So for calendar years 2019 and 20, it says we are implementing several documentation policies to provide immediate burden reduction, while other changes to documentation, coding, and payment will be implemented in 2021. So for 2019, and whenever you see CY, if you're looking through the documentation, that's calendar year. So it says for 2019 and 20, CMS will continue the current coding and payment structure for E&M and office outpatient visits, and practitioners should continue to use either their 95 or 1997 E&M documentation guidelines to document E&M office outpatient visits billed to Medicare. Okay, so it means that what we're doing now, and as an auditor, I'm kind of on top of you about this, you still have to document. So, but for 2019 and beyond, there are some policies they've tweaked. And here are a couple things that are going to affect your practice, because even though you still have to follow the guidelines for documentation, there are some things that are going to affect you. So one of the bullet points was elimination of the requirement to document the medical necessity of a home visit in lieu of an office visit. So basically, you don't have to double your efforts, if you will. So as long as it's there that the patient could benefit from one or the other, you don't have to get crazy about that home visit. Home visits are tough to come by because it takes the physician out of their space. And so there's a lot more documentation requirements, or there were, I should say, for medical necessity. You still have to prove that they need an encounter. You just don't have to be as crazy about it as you did as you do now in 2018. So this next bullet point, and it's still gray, but I'm going to put it out there anyway, and hopefully you will think about it, ponder it, and hopefully I'll get some feedback and some questions. You'll join the service that we have, because we're going to help give you an interpretation of this that will be compliant for your practice. So this next bullet point says, for established patient office outpatient visits, when relevant information is already contained in the medical record, practitioners may choose to focus their documentation on what has changed since the last visit, or on pertinent items that have not changed, and need not re-record the defined list of required elements if there is evidence that the practitioner reviewed the previous information and updated it as needed. So practitioners still should review prior data, update as necessary, and indicate in the medical record that they have done so. So you don't have to re-record every time, but you do still have to reflect that you did review it. And sometimes the only way to do that is to re-record it, or you're going to have to find a way to authenticate the record within your electronic health record. So to me, that's a little bit vague, but they're saying that you don't have to repeat the information if it's in your record, but then they could come and check as well if you're not basically auditing correctly. It says, additionally, we are clarifying that For E&M office outpatient visits, for new and established patient visits, practitioners need not re-enter in the medical record information on the patient's chief complaint and history that has already been entered by ancillary staff or the beneficiary. The practitioner may simply indicate in the medical record that he or she reviewed and verified this information. And then it says removal of potentially duplicative requirements for notations in the medical records that may have previously been included in the medical records by residents or other members of the medical team for E&M visits furnished by the teaching physicians. So they're trying to reduce that, what they call the burden of paperwork with the implementation of certain changes for documentation. The problem is that they're not being completely accurate, or I should say completely clear. It's, to me, and now it's as clear as kind of mud right now. But I at least wanted to read to you the bullet points they gave us so that if there was any question, you knew exactly the language that they had within the document. So that's what I'm kind of giving you on some of those bullet points. Now, beginning in 2021, Medicare tells us that they are going to further reduce burden with the implementation of payment, coding, and other documentation changes. So payment for E&M office outpatient visits, they say, will be simplified, and payment would vary primarily based on attributes that do not require separate, complex documentation. Specifically for calendar year 2021, it says Medicare is finalizing the following policies. So reduction, here's the reduction in the payment variation. So it says for E&M office outpatient visit levels, by paying a single rate for E&M outpatient visit levels 2 through 4 for established and new patients, while maintaining the payment rate for E&M office patient visit level 5 in order to better account for the care and needs of complex patients. Okay, are they kidding? So this is going to mean that you're going to have doctors who are going to bill level 2s and level 5s. So this is where, thank goodness that we've got, a couple of years to deal with this, because they still don't understand what they're doing. It says they're going to permit practitioners to choose to document E&M office outpatient level 2 through 5 visits during medical decision-making or time, instead of applying the current 1995-1997 E&M documentation guidelines, or alternatively, practitioners could continue using the current framework. Yeah, that's what doctors want to do. They want to continue using the same thing because they're only going to get paid on 3 levels of service the same rate. I just don't understand how they think this is helpful. It says, again, beginning for 2021, for E&M office outpatient levels 2 through 5, we will allow for flexibility in how visit levels are documented, specifically a choice to use the current framework, medical decision-making, or time. And then it says for E&M outpatient levels 2 through 4, when using medical decision-making or current framework to document the visit, they will also apply a minimum supporting documentation standard with level 2 visits. For these cases, Medicare will require information to support a level 2 E&M visit code for history, exam, or medical decision-making. Okay, so we got to take that basically as saying that they're saying that you're going to still have to prove that you have at least a level 2. And if it's medical decision-making, they basically are saying that they could come at any time and audit you. So if they see a trend of you coding level 4s or level 2s, they're going to say, show me what you're doing. And so what would be interesting here is, what if you had that complex patient? That patient who really should have been documented at a level 5, but you only documented at a level 2, thinking that, well, it really was a 4, but I want to get paid, I'm only going to get paid the same. And so this is where I think there still needs to be some conversation, and I think there will be. There'll still be some conversation about that. And then it talks about when time is used to document, practitioners will document the medical necessity of the visit, and that the billing practitioner personally spent the required amount of time face-to-face with the beneficiary. So time is definitely going to be kind of interesting when it comes to limiting how many patients you can see, during the day. That's why time is always going to be a counseling visit when you spent 50% or more counseling that patient, because there are typical times set with the E&M services that if you're stuck at those times, then that means that you're going to be limited on how many patients you can see, in a given day. They're also going to have some implementation of add-on codes. Again, this is 2021, that describe the additional resources inherent in visits for primary care and certain non-procedural specialized medical care. And then it says, though they would not be restricted by physician specialty, They said they're going to be coded with the level 2 through 4, and their use generally would not impose new per visit documentation requirements. But they're going to look at this adoption of the new extended visit, and I have a feeling that's going to be a further discussion. A couple other things that are going to happen. So if you are a primary care physician, then you're also going to have some new codes, and they're going to be what we call Hickspicks Codes, and those are G codes. And G codes basically mean that you're going to be able to have a pre-virtual check-in code. So they're saying there's going to be 2 defined physician services, and this is actually going to take effect in 2019. There's going to be a brief communication technology-based service, so they're calling it a virtual check-in. And this is basically to decide, the patient and the practitioner decide if the patient actually needs to come in for an in-person office visit. They're thinking that it would increase efficiency for practitioners and convenience for beneficiaries, but doesn't it still take the time of the physician? And they're also calling it, an evaluation of video images. So you're still going to have that technology as part of your practice. So we're going to keep an eye on that and just see what their policies are and what they're really looking at from that perspective. The fee schedule is going to get a raise, and I know that's something now, it's very slight. And don't forget, we still have the offset to pay for the Balanced Budgeting Act. So you're still going to have your, whenever they raise basically, I call it the country credit card because of how much debt we're in. They always seem to make Medicare pay for it. So with the budget neutrality adjustment to account for changes in the RVUs, that's required by law. We're going up to a conversion factor of 3604 from 35.99. So guess what? We're going to get a whole nickel increase for 2019. Don't spend it all in one place. I know I seem a little bit cynical, probably a little annoyed at this. The only reason is, and I like it when they move forward with services. I absolutely do. And I love change as long as it's good change. I mentioned that before. People say, well, change is good. No, good change is good. And sometimes I feel like, especially with the current Medicare administration, they throw things out there so that we can see that they're working instead of that they're working smarter. They're working harder to just make changes when they clearly have not done their due diligence and been transparent in what they're finding. So it's better than what the proposals were. The proposals that came out in July just scared everybody to death. And so it's definitely better. They've taken it down a notch. They said, we're going to take another couple years to really figure out how to implement this. Because one thing I think everybody misses on this, these changes are only for office visits, so office new and established patients. But this doesn't change how you document hospital admissions, hospital rounding visits, skilled nursing facility visits, and everything in the evaluation and management section of your CPT book. It's only for new and established patients in the office. So that means within your electronic health record, you're going to have 2 sets of templates. And that means expense, and that means adding things to your already established, electronic medical records. So I think those kinds of things is what finally, dawned on them. And we said, we understand what you're thinking, but you're not reducing the paperwork. You're only increasing the expense to the practice. So we need to find a way to be a little bit more consistent throughout the entire E&M services instead of just picking and choosing which E&M services are going to have a reduction in paperwork. And then Medicare is really getting on board with telehealth services. So as I look back at all of my podcasts, I'm now at number 53 since I mentioned we hit our year anniversary. And it's interesting because I've done 2 on telemedicine, and I'm actually going to do another one. It's going to be an advanced one just so you can hear what the updates are. But in the 2019 CMS proposal, they want to add Hickspicks Code G0513 and G0514, and these are considered preventative medicine codes. And these are for patients with end-stage renal disease, receiving home dialysis, or patients with acute stroke conditions. And so basically, this is when the patient is receiving home dialysis as the originating site, and there needs to be a clinical assessment, but the patient can't leave their home. So these are excellent updates. I love this kind of update because it speaks to the patient. Let the physician be involved with a payment when the patient can't get there, and let's see how that's going to work for these virtual visits. The biggest thing with virtual visits and telehealth and telemedicine is that it's a good idea in theory, but then when you actually look at the entire prospect of the whole thing, you have to keep in mind, well, what about the IT part of it? The information technology, the, asynchronous telehealth, video conferencing. When I hear telehealth, I want to hear a video. I don't just want to see that the patient made a phone call. That's not it. And remember, if the patient's calling from their home right now in 2018, Medicare doesn't pay for that. So, and some commercial plans don't either. So that's where I think they just need to be a little bit more transparent on what they're talking about. They're putting out these feel-good things about, we're going to expand telehealth, and they say there's going to be new codes, but then they forget to give us those background guidelines as far as, well, where does the patient have to be? Where does the physician have to be? And who gets paid what? Does the physician that's seeing the patient get paid something? Is there a monitor at the originating site where the patient is? There's a lot of details when it comes to this that you really have to make sure it's there. So we just want to make sure that you know that there are definitely some things coming up, but we want to make sure that you had, the information that was necessary for you. Otherwise, that could be just such an issue as well. So this week's episode has also been brought to you by Medical Economics, Smarter Business, Better Patient Care, medicaleconomics.com for the business of medicine, digital magazine, and health IT. And I will have an article up this week on medical economics on the new Medicare proposal. So take a look at that. Also, if you go to icdmonitor.com, I've got an article on there talking about some of the telehealth changes. So that can help you as well if you're interested in just kind of going through, reading some material and seeing what's available out there. The other thing that to keep in mind as well is when we're going through some of this information is Medicare puts things out and then they say this is the final policy. They mean it's sort of the final policy. So I've seen them kind of put something out saying it's final, and it means that it's a suggested final. And then by December or by January, I'm like, wait, you didn't say you were going to do that last year, and all of a sudden we got kind of a final. So there's something called a final. And so always make sure that you're updated. I think listening to the podcast is going to be very helpful for you because I have to be updated. I audit not just for privately for practices, but also for Medicare. But I also speak on a lot of topics and I have to be updated. My credibility depends on it. So I'm constantly getting alerts and information, daily. It used to be, remember the good old days when we used to get it every quarter? Yeah, that doesn't happen anymore. So we get it daily, and we just want to keep you as updated as we can. Wanted to tell you my coding question for the week. And this one was interesting. It was actually a practice in New York, and they were having some issues with smoking cessation. And I brought that up before as a revenue opportunity. So there's two codes, 99406 and 99407 in the CPT book, and they're time-based codes. One is 3 to 10 minutes, 99406, and one is over 10 minutes, 99407. But these codes have two things that you have to be careful of. Now, I mentioned time-based codes, meaning that you have to document time in the medical record. And it doesn't mean time saying 3 to 10 minutes was spent. It means actual time the physician spent talking to them about the benefits of quitting smoking. So I spent 4 minutes discussing the benefits of smoking cessation, gave the patient a prescription for Chantix. The patient will adhere to my medical advice, and then, discuss with patient next visit. Something like that needs to be in the note, but it has to have time. It can't be lengthy discussion with the patient. And that was the question that came up. They said, we're getting some denials on these. And we send in our documentation, our information, and we're still finding that they're saying we're holding up our decision. So there's another couple of things just to be aware of. There are frequency guidelines on smoking cessation. And so you usually get about 4 a year. It means they want to see a learning curve on the patient. So make sure that you know the frequency. And it's not 4 for your office, it's 4 for that patient. And so you may get a denial because they may have had that discussion as well at their primary care office or at another specialty practice. And so it's a big topic for cardiology practices, for dermatology. It affects the skin, for gastroenterology, because of the ramifications to the colon. So always make sure that you know that if you do get the denial, just check on that frequency, because you may not always know if they've used up all of their visits for that. But most payers now waive the copay and deductible like Medicare for smoking cessation. So it's nice to be able to bill it with an office visit. You don't even need the 25 modifier, and you're not having a problem with that. Oh, that was another thing I wanted to tell you on the proposed changes. Remember when I mentioned when the news came out in July that, if you were listening to the podcast back then, that they want to put that 50% reduction on that multiple payment item if there is an E&M billed with a minor procedure. That's been tabled also to 2021. So just know right now that's not there, even though you're going to see it from some commercial plans, but that was a huge reprieve because we are seeing it with other plans. So just keep in mind that things could change, but for right now, they're saying that they're going to push things for a couple of years. I'd also like to thank Medical Management Institute. Sign up now for the Medicare fourth quarter updates for physician fee schedules, coding, billing, and reimbursement information. I'll be presenting a webinar on this topic for them December 11th, and you can register at mmiclasses.com. Okay, so a personal insight. So now that I've done my Medicare update and ranting this week, my fascination with weather, everybody who knows me, they know that I'm a little bit kind of geeky when it comes to the weather. We had a thunderstorm and lightning storm here a couple of weeks ago. If you follow me on Instagram, Terry and CA, you can see my video. I love thunder and lightning. Remember, guys, I live in Southern California. It's either hot, warm, or hot. We have sun, and I'm not complaining. Okay, I'm a little bit whining, but I'm not complaining. We love it, and I love my beach. But it's nice sometimes just to see, rain and lightning and thunder and fall colors and anything different. So I try to search it out. And when I travel, my Weather Channel's on my TV if I'm not watching NFL Network. So just want to let you know, if you have any fun weather things, email them to me. I love weather. It's so fun to look at. Speaking of travel, for any of you cardiology coders out there, I will be in Dallas November 15th and 16th. If you'd like to join me for my 2-day cardiology live seminar, you can find my link on my website under live seminars at terryfletcher.net to register. So everyone, make it a great day, and thank you for listening today, and we hope the insight gave you some tidbits to think about. And next week, I am going to bring back about your vendors and talk about, your external hires, and also talk about the offshore and outsourced coding. Then we go out of country. So tune in next week. Definitely. We just wanted to bring you this breaking news since the fee schedule came out today. So again, make it a great day, and thanks for listening.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Cessation Music.